Hello and welcome once again to APHA's 15 on COVID-19 series. I'm your host, Dan Zlott, Vice President of Education here at APHA. Today we're going to be doing an update on hydroxychloroquine. I'd originally intended this episode to be an update on all things COVID-19, a couple of drugs maybe, talk about some interesting updates as we're learning about the stability of the virus in the air and on surfaces. However, the literature around hydroxychloroquine has just exploded over the last week. So without further delay, let's go ahead and dive in and take a look. I still have nothing to disclose. Here are your learning objectives for today's episode. All right, so as we start looking at hydroxychloroquine, there have been a number of new trials as well as an update of previous data that has been published since our initial episode on March 23rd. And most excitingly, we are finally starting to see some randomized controlled trials come out. So we'll take a look at that and see what the data is telling us. All right, so you may remember that in our initial episode, we talked a lot about the trial by Gautret et al. That was really aimed at looking at virologic clearance in patients with COVID-19. That particular study only looked at virologic clearance. It really didn't look at clinical outcomes at all. And that was a group that used the combination of hydroxychloroquine and azithromycin. And they noted that by day 6, they had, basically 100% clearance in patients who received both hydroxychloroquine and azithromycin. Now, so they've gone back and they've updated their data, and so that's the information we'll be talking about first. So this is a single institution, open label, uncontrolled observational study. So very similar to the first study, a lot of limitations there. The primary outcomes in this study were clinical outcomes. So instead of just looking at virologic clearance, now we're actually looking to see how patients do clinically. They're looking at contagiousness, and they're looking at this from a couple different standpoints. The first was looking at by basically the presence of viral RNA in terms of looking for PCR positivity. And then they're also looking at viral culture. So they actually take swabs from these patients and then put them in growth plates that are plated with cells that we know are susceptible to the SARS-CoV-2 virus or the COVID-19 virus, and see if the samples from the patients are able to actually transmit or infect these cells with the virus. So that's an interesting bit of information. There's been a lot of question about whether or not PCR positivity correlates with the ability to actually infect someone, and so they're actually going to take a look at this. So that's interesting in and of itself. And then they also take a look at the length of stay in their infectious disease unit, or IDU. I will do my best to enunciate clearly there. We're also going to be talking about ICUs in just a little bit, as you'll see. So who were the patients in this study? These were mildly infected patients, quote unquote, admitted to the hospital between March 3rd and March 21st. And this took place at a hospital in Marseille, France, so a single institution. All patients were COVID-19 by nasopharyngeal swab PCR. They were admitted to the IDU, the infectious disease unit. And these patients were grouped into two categories. The first group were patients who had upper respiratory tract infection symptoms, so that's going to be rhinitis or pharyngitis. They also included patients with isolated low-grade fever or low-grade muscle pain. And then the other group were patients with lower respiratory tract infections. And these are patients who had signs or symptoms of pneumonia or bronchitis. So they had 80 patients total in this study. The median age was 52, and you can see the age range there. The male to female ratio was 1:1, and 57.5% of patients had at least one comorbidity. In terms of the most frequent comorbidities that they saw, they listed hypertension, diabetes, and chronic respiratory disease as the most frequent comorbidities that they saw. The median time from symptom onset to hospitalization was 5 days, but there was a pretty significant range there, as you see. And just over 40% of patients presented with upper respiratory tract infection symptoms, and almost 54% of patients had lower respiratory tract infection symptoms. Interestingly, 15% of patients were febrile, only 15%. And that's unusual. If you look at the rest of the literature, somewhere between 40 to 50% of patients are febrile upon admission to the hospital. So I'm not sure what that means, but so take that for what it's worth. 5% of patients, so 4 out of the 80, were asymptomatic carriers of COVID-19. So what was the intervention? It's the same intervention that was described previously. So this is hydroxychloroquine 200 milligrams by mouth 3 times a day on days 1 to 10. One change, though, in the prior study, they only gave azithromycin to patients who were at, quote unquote, at risk for superinfection. And so here they gave azithromycin to all of their patients based on their previous findings. And so that was azithromycin, typical Z-Pak dosing, 500 milligrams on day 1, and then 250 milligrams a day on days 2 through 5. Patients with pneumonia, as well as a national early warning score. I won't go into what that is just for the sake of time. If you're interested, do check out the article. So if you had a news score higher than 5, they were also started on ceftriaxone, and the authors didn't report their dosage of ceftriaxone that they were using. The intervention was not started or was discontinued if patients had a QTc of more than 500 milliseconds. Other medications that prolong QT were discontinued, and patients with echocardiograms that showed patterns of concern were not treated. So we're getting a little bit more information about how they're handling their patients with regard to cardiac issues, QTc prolongation, and so that's some additional information that we're gleaning in terms of, maybe some finer points in terms of patient selection, patient management. So what were the results? To start off with, patients were included in the analysis if they received at least 3 days of hydroxychloroquine, azithromycin, and had at least 6 days of follow-up. So it's not a true intention to treat analysis, but they are clearly defining who they included in their final analysis. The median time from symptom onset to initiation of hydroxychloroquine azithromycin was 4.9 days, and then 94% of patients basically started the intervention on the day of admission to the hospital or the day after. So these guys were very aggressive about starting this the hydroxychloroquine azithromycin therapy. 81.3% of patients were discharged by the end of the study period. So in the patients who actually got discharged, the mean length of stay was 4.6 days. So we'll see in a second. I don't know exactly how to evaluate that because there were still 13 patients, or 16.2% of patients, who were still in the infectious disease unit at the end of the study period, and as well as 1 patient in the ICU at the end of the study period. Now, of the 80 patients total, 3 patients were transferred to the ICU over the course of the study period. 2 patients were transferred back out of the ICU to the infectious disease unit, and again, 1 patient remained in the ICU at the end of the study period. 1 patient died over the study period, and interestingly, that patient died in the infectious disease unit. They were never transferred to the ICU. And if you look at the supplementary materials, that particular patient was on corticosteroids for 5 days prior to hospital admission. And it's not clear why that patient was on corticosteroids and what dose of corticosteroids that patient was on. So I don't know if it's low dose, high dose. That may obviously have some implications in terms of levels of immunosuppression and potentially reasons for that patient's immunocompromised state and potentially adding to his death. So again, we don't really know what the whole story is there. So it kind of have to, take it with a grain of salt, like so many things related to COVID-19. All right, so let's now get into some of the virologic outcomes. So remember that Gautreinol are the group that has hypothesized that the combination of hydroxychloroquine and azithromycin accelerates or speeds up the rate of viral clearance. So in this study, 83% of patients were PCR negative on day 7, and 93% were PCR negative at day 8. So they claim, significant viral clearance. Of course, there's no control, so we can't see if it's really faster or not. The number of presumably contagious patients, and they define that as patients who have a PCR copy number of greater than 34, reached 0 on day 12. And so, you know, again, there's a lot of controversy potentially about does the presence of viral RNA equal infectiousness? Can you actually spread the disease to others? So they've tried to answer that a little bit. And so what they did is they took viral cultures. Again, you know, they swabbed patients and took the respiratory secretions they got and they plated them with cells that are susceptible to viral infection. And so when they did that, they found that respiratory samples were not able to infect the cells in 97.5% of patients at day 5, and that by day 9, none of the patients had positive viral cultures. And so that would seem to more or less line up with the PCR results, maybe a little bit faster, and maybe a higher percentage of patients who are not able to infect others. The challenge here is that in the way that they selected their patients to collect these respiratory samples from and perform viral cultures, they said that they performed a convenience sample. So that means they didn't have strict criteria for who to select and who to exclude. So presumably they may have selected patients who were doing better. You know, it's possible. I'm not saying that's what they did, but it's possible. Likewise, they may have selected patients who had more respiratory secretions because it would be easier to get a respiratory secretion sample from them. You might presume that that would be a negative factor, and that those patients would be more likely to be infectious. So those are all hypotheses. We don't really know, and we also don't know exactly who is included and how they selected them. So all of those things that I just threw out there are, you know, hypotheticals. They're possibilities. So it's difficult to draw solid conclusions from that, but it's our first look at someone who's actually comparing viral culture data with PCR information. They talk about adverse events, and they say that they were rare and minor, and that's the extent of their discussion of adverse events associated with hydroxychloroquine and azithromycin. They do note, however, that one patient needed to discontinue treatment on day 4 due to concerns over a potential drug-drug interaction. The authors don't go into any detail about what that drug-drug interaction was or why it was necessary for the patient to have whatever that other drug was over the intervention that was being studied. So what are the limitations? Well, as we've already discussed, it's a single center, open label, uncontrolled observational study. It's anecdotal, it's descriptional only. So you have to take it for what it is. There is no control, so we don't know if this is better or worse than, you know, just standard care. So we'll hopefully get to that in some of our randomized control trials in just a little bit. They only treated patients with mild symptoms, so the description we see here, it's not fair to apply that to patients with moderate or severe disease. And as I said, very limited discussion of adverse events. All right, so now let's take a look at another study. And this is a study that is really going to, you know, try to counter the claims by Gautret et al. So this was a single center, non-randomized, open label, uncontrolled trial in 11 consecutive patients who were admitted to another institution, another hospital. So who were the patients? And we're going to see some interesting differences here. 7 males, 4 females, about 60-ish years old, 59 years old. You can see the range there. 8 patients had significant comorbidities, and that was obesity. So 2 patients were obese. Of particular note, 3 patients had solid cancer. 2 patients had hematologic cancer. So these are really different patients. And this was just a short letter to the editor. It really is not a full study write-up. So we don't know where they're at in their treatment course. We don't know, are they, you know, neutropenic at the time of admission? How are they newly diagnosed, or have they been through cycles and cycles of chemotherapy? With hematologic malignancies in particular, the type of hematologic malignancy can actually cause you to be immunosuppressed even without treatment, again, just depending on what type of heme malignancy you have. And so, you know, it's not an apples to apples comparison compared to some of the other groups we've seen from Gautret et al., from some of the other groups coming out of China. So we'll talk about that when we get to the outcomes in just a little bit. One patient had HIV infection as well. So the intervention here was identical to that described by Gautret et al. They wanted to see if it worked as well as Gautret claimed. And they found that Bottom line, it really didn't. 10 patients had fever and required O2 support. They didn't say whether that was high flow or just normal nasal cannula. Within 5 days, however, they noted that 1 patient died, 2 patients were transferred to the ICU, and 80% of patients had detectable viral RNA levels at days 5 and 6 after the initiation of therapy. And keep in mind that Gautret et al. In their first study claimed that with this combination, by day 6, 100% of patients had cleared the virus. And then in the follow-up, I think it was 85% had cleared virus by day 6. So significant clearance. These guys are saying, nope, that's not the case. We're seeing something different. And they also had to discontinue hydroxychloroquine and azithromycin in 1 patient due to an increase in QT interval from 406 milliseconds at baseline all the way up to 460, 470 when they started hydroxychloroquine azithromycin. That's probably a little conservative, but again, not being in the clinical scenario, it's difficult to understand the thought process there. But typically 500 is a cutoff we use when we start looking at when to discontinue drugs that prolong QT. All right, so limitations, same as before, single center, non-randomized, open label, uncontrolled trial. It's descriptive only. Very small N, only 11 patients. And as I said, a very different patient population compared to what was previously reported. So in terms of virologic clearance, when you have patients who are potentially immunosuppressed, the thing that does the clearing of the virus is your immune system. Drugs can help stop the virus from replicating, but they don't destroy virus necessarily. So the immune system still plays an important cleanup role. So we have to keep that in mind as well. All right, well, let's run through one more study for today, and then we'll pick up the rest on Monday. So this was a single-center prospective randomized trial in 30 patients. So for the first time now, we're in a prospective randomized setting, so that's exciting. So in this trial, 15 patients were randomized to hydroxychloroquine 400 milligrams a day for 5 days, plus conventional treatments. 15 patients were randomized to conventional treatments alone. And we really don't know what the conventional treatments are. It's important to note that the article is written in Chinese, so unfortunately I don't read Chinese, so I was relying entirely on the English abstract. So all of this data comes straight from the abstract. The primary endpoint in the study was viral clearance by PCR assay 7 days after the date of randomization. So what were the results? Well, here's a quick table. Very different data, again, than what Gautret et al. Conveyed in their initial article and in their follow-up article. So here, when you look at viral clearance on day 7, you see that there was not a statistically significant difference between the hydroxychloroquine group and the control group. In fact, the control group had a higher clearance rate on day 7. So very interesting. When you look at the median time from admission to viral clearance, again, you see that there was not a statistically significant difference between the two groups. And in fact, again, the control group had a shorter time from admission to viral clearance than the hydroxychloroquine group. Again, very different than what Gautret et al. Said. When you start to look at some of the other characteristics in terms of time from hospitalization to temperature normalization, whether or not patients had radiological progression on CT scan, again, there's no significant difference there. Because this is a study with a relatively small and only 30 patients, we might see some differences if we had more patients enrolled. However, really not much in terms of statistically significant differences here. One thing to point out is that this group really didn't look at clinical progression, at least not in the abstract. So they did note in the abstract, however, that there was only 1 patient who progressed on to severe disease, and that patient was in the hydroxychloroquine group, again, with a small n, and they didn't even do a statistical analysis on that, so it's difficult to draw any significant conclusions there. But again, the main takeaway point here is that virologic clearance doesn't seem to be improved in the hydroxychloroquine group as compared to controls. So again, another piece of evidence that kind of is counter to what we're hearing from the Gautret group. So what were the limitations of this study? Again, very small n, only 30 patients. different intervention. So again, this was just hydroxychloroquine. It was not hydroxychloroquine plus azithromycin. It's unclear what role the azithromycin plays in terms of antiviral effects or in controlling the disease process. But again, different intervention, so can't quite compare apples to apples. The dosing of the hydroxychloroquine was also different. And as I mentioned before, it was written in Chinese. It's not a study limitation per se. It's a limitation of the person reviewing the literature, me in this case, just because I don't know what was in the full article. So there may have been additional information there that would be helpful in helping to dig through some of the data that was presented in the abstract. For example, what were the other standard treatments? Did they include antiviral agents or not? Were those the same and equal distribution in each group, etc.? So I'm unable to gather that just from the abstract alone. And so with that, we will go ahead and wrap up for today. We've got another study, actually a couple more studies that are also randomized control trials, and they're really interesting. So I'll leave you with a teaser there. They confirm both groups' data. So both those that say that the viral clearance is maybe not as good as we think, but maybe there's also benefit. So please join us on Monday. That will be April 20th. And we'll touch base on those other two hydroxychloroquine studies. And if we have time, we'll also touch base on some other drugs, remdesivir perhaps, and then also some of the new characteristics about the COVID-19 virus that we're learning in terms of aerosolization and surface stability. So with that, we hope to see you on Monday, April 20th. Thank you so much for joining us. As always, please keep the questions coming. We continue to receive lots of wonderful questions. And again, a lot of these updates and things that we're providing today are a result of the many questions we've been getting in our inbox. So please continue to email covid@aphanet.org. We look forward to hearing from you. And once again, we hope you'll join us on Monday for some additional updates on some of the topics we've already covered. And we look forward to seeing you then. Thank you very much.